Hi, everyone. Thanks so much for joining and spending your evening with us. We're so excited. Um, I just wanted to take a few seconds to just let everyone know that we did send out an email for the pre-test question, and in order to get CME credit, you're going to want to take that. So if you haven't yet done it, while I'm doing this introduction, just quickly take that pre-test, and then the post-test and evaluation for this program will go out as soon as we're done. Can we go to the next slide? Awesome. This is our accreditation statement. There's one CME credit available. And here are the disclosures. There are no financial relationships to disclose. And of course, this program would not be possible without the support of our grants from AbbVie, Bristol Myers Squibb, Eli Lilly & Co., and Janssen, and of course, our grant from the CDC. So thank you to all who sponsored and for all the support for this program. Perfect. Okay, so without further ado, I just want to take a second to introduce Dr. Dommasch. She's an assistant professor at Harvard Medical School and a dermatologist at Beth Israel Medical Center and Fenway Health, a community health center in Boston which focuses on caring for the LGBT community. She specializes in the dermatological care of transgender patients and also has an interest in drug safety and pharmacoepidemiology, big word. She completed her dermatology residency at the Boston University School of Medicine. So I'd just like to thank you for being here with us and for all the important work you do with the community. And without further ado, passing the virtual mic to you.
All right, and I would like to thank the National Psoriasis Foundation for having me here tonight. So today we're going to go over some basic LGBTQ terminology. Hard to have a talk about LGBTQ issues without going over the basics first. We'll go over some health disparities and some unique dermatological needs among LGBT individuals with psoriasis, and highlight the need for more data in this population, including clinical trials and population-based research. So sex, also known as sex assigned at birth, tends to be based on the appearance of external anatomy at birth. It may or may not align with current gender identity or gender expression. Gender is a social construct in a binary model, usually divided into masculine and feminine. Gender identity is how someone feels internally, so how their internal experience of gender. And gender expression is how that they publicly present their gender to the world. Gender identity is not inherently defined by sex, and sexual orientation does not equal gender identity. And people that are transgender or of different or gender queer can be of any sexual orientation. So transgender is someone whose gender identity or internal sense of gender differs from their sex assigned at birth. So female to male refers to someone that was female at birth or assigned sex as female at birth and now identifies as a male, also referred to as transmasculine. And male to female is the opposite of that. So someone that was had a sex assigned at birth as male and now identifies as a woman. Cisgender is someone who has a gender identity that aligns with their sex assigned at birth. And then in between there are people that don't necessarily identify as one gender or the other. So there are terms such as gender queer or gender fluid. And all of those terms can be kind of coalesced into a term called gender diverse. Or gender minority. And again, sexual orientation is how one person identifies their physical and emotional attraction to others, and transgender people can be of any sexual orientation. Gender affirmation is the process by which individuals are affirmed in their gender. This can be done in several different ways. So first is self-affirmation, so internally affirming your own identity. Social is through changes of names, pronouns, gender expression. Legal involves modifying gender markers on government documents like licenses, passports, even birth certificates. Medical usually involves gender-affirming hormone therapy or sometimes pubertal suppression. And then surgical and procedural involves what we refer to as top surgery, so mastectomy or breast augmentation, what's often referred to as bottom surgery, so genital gender affirmation surgery, including vaginoplasty and phalloplasty, also facial feminization surgery, and minimally invasive procedures like neurotoxins or fillers. So why does this all matter for us psoriasis patients? So having data or knowing about our patient's sexual orientation, gender identity, can give us some more information about how there's intersectionality between different conditions that we see in dermatology, like psoriasis. So we know that patients with psoriasis may have a higher risk of mental health disorders, such as depression, or may feel stigmatized, so that risk may be increased among patients who are sexual and gender minorities. Getting an organ inventory or understanding our patient's anatomy is going to be really important for medication counseling. So if a transgender man still has their uterus and ovaries, that's really important if you're going to prescribe something like methotrexate or acitretin that may affect future pregnancy. And then understanding sexual behaviors among our patients is also very important. Again, pregnancy potential is going to affect prescribing. And then also understanding a risk for different sexually transmitted infections. So if you're prescribing someone immunosuppressive and they're at risk for HIV, you may want to consider checking that every year. The number of individuals in the U.S. That identify as LGBT has been increasing quite a bit. So in 2020, about 5.6% of the U.S. population identified as LGBT, and it was up to 7.1% in 2021, with 1 in 5 Generation Z adults identifying as LGBT. It seems to be increasing primarily among the younger population, with bisexual identification the most common. So if you don't see a lot of these patients in your practice already, you may be seeing more patients that identify as LGBT in the future. And the data on transgender demographic is a little bit, there are different reports, but we have some data from the CDC suggesting about 0.6% of U.S. adults identify as transgender or gender nonconforming. But a more recent Pew Research study from 2020 found that about 1.6% of U.S. adults. And similarly to the LGBT population, we find that identification as transgender or genderqueer or gender diverse is particularly high among adults younger than 25, with the Pew Research study estimating at 3.1%. And the majority of adults who identify as transgender identified 38.5%, so the majority identify as transgender women, but a slightly lower percentage identified as transgender men. And about a quarter of those patients reported that they were gender nonconforming. The prevalence of psoriasis among sexual and gender minority patients is likely around the same as the general population. There aren't too many studies looking into this. One study found that the prevalence of psoriasis among transgender individuals was about 2.6% among transmasculine individuals and 1.1% among trans feminine individuals. And about 17% of those individuals surveyed felt that there was a link between their psoriasis and the gender-affirming hormone therapy, although there has been no evidence of this to date. So sexual and gender minorities experience, unfortunately, many different health disparities across multiple domains, including risk behaviors, mental health disparities, and physical health disparities, so much that in 2016, the NIH designated SGM as an official health disparities population that's along with racial and ethnic minorities and other disadvantaged populations. And these, and I wanted to talk about these because these may actually sometimes influence treatment decisions and outcomes. So SGM individuals have a higher prevalence of smoking. They are known to have higher risk sexual behaviors and higher rates of sexually transmitted infections like HPV and HIV. As a group, they have higher rates of depression, anxiety, and suicide. And among gay men, there are high rates of indoor tanning and skin cancer. There are also higher rates of HIV, AIDS, and other STIs, as well as anal cancer among gay men and transgender women. Transgender individuals are especially likely to be uninsured and also live in poverty, about almost a third. There are also higher rates of cardiovascular disease among LGBT adults, and this is potentially impacted by hormone therapy, minority stress, substance abuse, and physical activity. It's well known at this point that patients with psoriatic disease are at higher risk of multiple comorbidities, including cardiovascular disease, metabolic syndrome, obesity, dyslipidemia, diabetes, anxiety, depression. And given that patients who identify as SGM also have higher risk of all these comorbidities, there's a potential that there's intersectionality between these two conditions, or between psoriasis and those who identify as SGM. So there is some data emerging that SGM patients with psoriasis may have worse outcomes. So there's one study, only one study thus far, that looked at intersectionality between psoriasis in sexual minority individuals, and they found nearly four-fold higher odds of clinical depression compared to heterosexuals with psoriasis. I wanted to go over some of the comorbidities that we see that are seen in SGM patients, and just thinking about how this may impact treatment for patients with psoriasis. So men who have sex with men, abbreviated as MSN there, have higher rates of skin cancer and indoor tanning, which may have implications for phototherapy. So if someone's been indoor tanning for 20 years, you might not want to start them on treatment with phototherapy. There's a higher prevalence of smoking and cardiovascular disease among SGM patients, so this may have implications for treatment with JAK inhibitors, acitretin, cyclosporin. Higher rates of HIV and STIs among men who have sex with men, and transgender women could potentially influence your treatment with immunosuppressive medications like biologics, JAK inhibitors, and then patients with a higher rates of depression, anxiety, and suicide, you want to be careful with treating them with apremilast, acitretin, or botulinumab. I wanted to spend some time talking about monkeypox today because this is something that has been overwhelmingly affecting men who have sex with men, not exclusively, but overwhelmingly so. So just this past weekend, on July 23rd, the World Health Organization declared the monkeypox outbreak a public health emergency. And there's some evidence to date that individuals who are vaccinated for smallpox may be at reduced risk for monkeypox. However, routine vaccination for smallpox was halted in 1972, so anyone under the age of 50 is almost certainly unvaccinated. It is spread through skin-to-skin contact, so it's not considered a sexually transmitted disease, but because it is spread through close skin-to-skin contact, that's essentially why it's predominantly affecting men who have sex with men. The total number of confirmed cases in the U.S. as of yesterday was about 3,500. Right now, vaccines are currently being distributed for post-exposure prophylaxis or expanded. It's called PEP. So individuals exposed or have a high risk of prior exposure. And if given between 4 and 14 days after the date of exposure, vaccination may reduce the symptoms of the disease, but may not prevent it. Ideally, it's given within 4 days of exposure. There are 2 vaccines currently licensed by the U.S. Food and Drug FDA, available for preventing monkeypox infection. So Jynneos, which is the newer one, and ACAM 2000, which is the older one. Right now, there's a limited supply of Jynneos, although more is expected in the coming weeks. there's an ample supply of ACAM2000, but it has a lot of restrictions, a lot of contraindications. We're going to go over that. JYNNEOS contains a live virus, but it does not replicate efficiently in human cells. It's administered as 2 sub-Q injections 4 weeks apart. It takes about 2 weeks after the second dose for maximal immune response. It's licensed by the FDA for use in prevention of smallpox or monkeypox. There's no data on efficacy for this vaccine for post-exposure prophylaxis, although that's what it's been being used for at this point. There's not enough vaccine available at this point to just distribute widely. And it has, interestingly enough, it has been studied in people with HIV and is considered safe for use in immunocompromised patients. ACAM2000 is a live vaccinia virus that is actually replication competent. It's 1 injection, takes about 4 weeks to develop a maximal immune response. Following successful inoculation, the lesion will develop at the site of the vaccination, which is known as a take. That might take 6 weeks or more to heal. It's licensed only by the FDA for use against smallpox, but they are allowing it for use against monkeypox under an expanded IND. It should not be given. It is contraindicated in patients who are on immunosuppressive medications, or those with atopic dermatitis, eczema, or other exfoliative skin conditions, and they do list psoriasis in there. So this is contraindicated in patients with psoriasis or those on immunosuppressive medications like biologics or others. And this is why in patients who are immunosuppressed, they are at risk for uncontrolled viral replication. So these are pictures of progressive vaccinia in patients, and patients with skin conditions could develop spread through, I think the thought is through open areas of skin. So most notably in patients with eczema, but I think there's a potential of uncontrolled viral replication with patients with psoriasis as well. So, and this is just a chart that was made by the CDC on what are the contraindications for ACAM2000 and JYNNEOS. And really the only contraindication for JYNNEOS is a vaccine an allergy to the vaccine, one of the components of the vaccine. So the other thing to note is that, so JYNNEOS is a safer alternative than ACAM2000, but still there's very limited supplies. It is safe for use for patients who are on immunocompromising, who have immunocompromising conditions or are on immunosuppressive medication. However, we don't really know how effective the response will be after vaccination. There's no real way to measure response to vaccination at this time. So something to keep in mind if you have patients that are getting this that are on immunosuppression. And right now it's being, JYNNEOS is being distributed by the CDC as part of the National Strategic Stockpile. They are supplying the vaccine to different states who are then distributing it. And they're using it for patients with known contacts who are identified by public health, or presumed contacts who, so anyone who's had a sexual partner in the past 14 days that was diagnosed with monkeypox or had multiple sexual partners in the past 2 weeks in a jurisdiction with known monkeypox. So more vaccine is likely on the way. The government has ordered multiple doses. It's probably going to take a while for this for them to produce enough vaccine to support the current need. That may be an option for prevention among psoriasis patients in the future. There is some thought that patients with psoriasis could potentially be at higher risk of severe disease. Again, just open areas of skin could potentially create a risk for spread, although there's limited evidence of this to date. Right now, the only treatment available, aside from the vaccines, is something called TPOXX, which is FDA approved for the treatment of human smallpox disease, not for monkeypox. However, they have an expanded access IND. Patients with psoriasis or on tumor necrosis factors may be eligible for this treatment, so just something to keep in mind. It has to be obtained through the CDC. There's a whole application It seems a bit complicated to get, but it is possible for our patients with psoriasis. All right, so switching gears a little bit, I wanted to talk about some other conditions that you may see in the SGM population. So there have been several cases of secondary syphilis mimicking psoriasis and palmoplantar psoriasis. Both primary and secondary syphilis have been increasing pretty dramatically in the US over the past few years, especially among men who have sex with men. So definitely something to keep in mind for this population. Another clinical condition that may be seen more commonly among the SGM population is SCCIS of the glans penis, also known as bonoid papulosis or Bowen's disease. This is most commonly due to HPV types 16 and 18. It can develop into invasive SCC, and it can look very similar to psoriasis. So anytime, especially in this population, if you have a genital plaque that is not responding to typical therapy like topical steroids, definitely consider doing a biopsy. There's a much higher, multiple studies have shown a much higher prevalence of HPV among trans feminine patients and also in men who have sex with men compared to cisgender individuals, though still quite high within cisgender individuals, 45% in men and 40% in women, but certainly higher in our SGM population. Something to keep in mind. I wanted to spend a good portion of this talk talking about specific considerations in treating our transgender and gender diverse patients who may have psoriasis. So transgender patients may or may not be on gender-affirming hormone treatment. And I think it's important to be aware of this because this may affect lab results, risk of comorbidities, and risk of adverse events with medications that are used to treat psoriasis. And to date, no controlled clinical trials of any feminizing or masculinizing hormone regimen have been conducted. So all of these medications are used off-label. So for feminizing hormone therapy, most of these patients are receiving estrogen plus or minus another anti-androgenic agent. So it's usually some S17 beta estradiol, usually given in sublingual or transdermal form. Intramuscular estradiol is rarely used due to thought for increased risk of venous thromboembolism. And these patients are also usually getting an anti-androgen, usually spironolactone in the US, cyproterone acetate sometimes outside the US. For masculinizing hormone therapy, most patients are receiving some form of testosterone. So typically intramuscular testosterone tends to be the cheapest formulation, but they can also get it in gel, cream, patch. There's also something called Testapel, which is these testosterone pellets that are implanted into the subdermal fat on the buttocks, and those usually last for about 3 to 4 months. Possible side effects that may impact psoriasis treatment. So among patients that are receiving estrogen for feminizing hormone treatment, there was a great study that was done using data from Kaiser that found that transgender individuals were at a much higher, had a much higher incidence of venous thromboembolism and also ischemic stroke when compared to both cisgender men and cisgender women, and that risk increased over time. Unclear, there was maybe a suggestion that there may be a slight increased risk of MI, but there wasn't enough, probably underpowered to look at that. And they really found like no increased risk of cardiovascular risk or stroke or venous thromboembolism among those transgender men on testosterone, interestingly enough. Feminizing, so in terms of affecting lipid profiles, this might be important for patients that we're considering treating with acitretin. So feminizing hormone therapy really hasn't been, the evidence has been mixed, but mostly thought to not affect cholesterol, LDL, or HDL. Testosterone therapy, however, has been consistently associated with decreased HDL and increased triglycerides. So again, something you want to keep in mind if you're thinking about starting someone on acitretin. There's no clear evidence that estrogen or testosterone therapy can bring on or worsen mental health conditions. However, injected forms of testosterone and estrogen, which may have more cyclic levels of hormone, may sometimes be implicated in worsening of existing mood disorders. So it's just something to be aware of. Overall, gender-affirming hormone therapy has, in study after study, been linked to improvement in social functioning and other mental health conditions. But I have had more than one patient, especially I see a lot of transgender men who are on, or gender diverse patients who are on testosterone that have brought to my attention as their testosterone dosage goes down, they have noticed a worsening in the mood. So it is just something to be aware of in this population, especially if they are taking a medication like apremilast or acitretin that may affect mood. So I just created a chart kind of going over these different risks. So in patients receiving estrogen, probably want to be really careful about treating them or not treat them with JAK inhibitors, which may also increase risk for MI, stroke, cancer, or more so MI, stroke, and blood clots. Patients receiving testosterone, again, you probably want to be careful about treating them with acitretin, and then patients who are taking, especially intramuscular hormone therapy, be careful with apremilast, acitretin, or adalimumab, which may impact mood as well. Transgender and gender diverse patients may also undergo gender-affirming procedures such as facial feminization, masculinization, which can include surgery or fillers, neuromodulators, top surgery, enhancement or removal of breasts, and genital gender affirmation surgery, or what's referred to often as bottom surgery, which is modification of genitalia. I wanted to go over this quickly because we'll talk about it in regards to phototherapy. So I just want to make you aware of kind of what is done for gender affirmation surgery. So for men or for female to male patients, so they can undergo phalloplasty. That can be done in one of two ways, typically done in one of two ways, using a forearm flap. So that involves using the medial half of the forearm, or using something called the anterior lateral thigh phalloplasty, which the surgical area is from the anterior aspect of the thigh. And then metoidioplasty, which is surgical construction of a hormonally enlarged clitoris. Shouldn't affect really treatment at all. So, and then for feminizing surgery, these are patients who have creation of a neovagina using the penile shaft skin and scrotum. And many of these patients will require laser hair removal prior to gender affirmation surgery. So these genital region, or the donor sites, need to be treated with permanent hair removal before they're used for surgery to prevent complications such as hair growth within a neovagina or hair growth within a neourethra. As you can imagine, that would cause many issues. Interestingly, I was thinking, okay, so are patients who get laser hair removal, or are they at possible risk of developing psoriasis in those areas? So there was actually one case report of this occurring, something called the Kebner phenomenon. Where you have some trauma to the skin and psoriasis to flare, but there was only one case report, so it seems pretty rare. So I wouldn't worry about that too much in your patient population. However, uncontrolled psoriasis could affect laser hair removal and could affect gender affirmation surgery. So anyone considering undergoing surgery, you really want to make sure that their psoriasis is under control, and they also want to discuss with their surgeons whether they're not going to whether they will have to hold any medications that they are taking for their psoriasis. So in terms of phototherapy, transgender patients may have unique needs when they're receiving treatment with phototherapy. There was a wonderful article that was recently published by Dr. Callis and Dr. Bose from the University of Washington, going over kind of all the specific needs that transgender patients may need. If you haven't seen it, it's a great read. I would definitely check it out. And some of the issues that they brought up in this article was phototherapy units may be an area where there is less privacy and may be hard to keep things confidential. And for transgender patients, they often want to avoid being outed. And so confidentiality is really important for these patients. And they may have unique shielding needs based on their anatomy, prior surgeries, or planned surgeries. And so they have some recommendations, especially around communicating gender identity with staff and needs before treatment, before they enter the phototherapy unit. And they have some great sample phrasing in this article. So making sure to introduce yourself, one way, and to obtain their preferred pronouns. So one way of getting pronouns way of obtaining pronouns from a patient is to introduce yourself along with your preferred pronouns, and then asking the patient for theirs. And then going over, taking an accurate medical history, reviewing gender affirming care, and phrasing it in a way where you want them to know that it's relevant to the planned phototherapy treatment. And then going over different genital shielding options and figuring out, based on their anatomy, what's going to work the best for the patient. We just talked a little bit about the phalloplasty, but these are areas you want to make sure that if a patient is planning on undergoing phalloplasty, that they shield these areas during surgery, or they shield any scars, or use sunscreen on any areas where they may have had prior procedures, such as mastectomy. And I'd like to, the last kind of topic that I'd like to talk about is collecting data on sexual orientation and gender identity. So we really need more data. Data is what drives policy decisions, and really is what's going to make, I think, drive better outcomes in the future. So right now, we really have lack of comprehensive data on sex and gender identity. So we really don't know. We know some of the disparities, and they're not good, but many of the disparities in this population remain unknown, especially among our psoriasis patients. So in 2020, the National Academies of Sciences, Engineering, and Medicine released a report that indicated that the standard of the NIH should be to collect data on gender and report it by default, and they recommended this two-step method here. So asking about sex assigned at birth, and then the current gender. And they recommended that this data be collected for all population-based research. And then the Sexual and Gender Minority Research Office at the NIH helped develop standardized measures for sexual orientation and gender identity in this FENX toolkit. So this is a publicly available web-based catalogs of recommended measurement protocols for conducting all kinds of biomedical research, for use in clinical trials, EHRs, population surveys. And by using standardized measures, it can facilitate cross-study analysis, so meta-analysis. And so using standardized measures is really important for meta-analysis, especially when you have a not huge number of patients. If you're trying to be powered to look at certain outcomes, this is really important. And these are, I didn't include the section, or actually I did. So they also recommend doing the two-step method with sex and gender identity. It's a little bit more nuanced, the options for gender identity in the FENX toolkit, and they also have a measure for asking about sexual orientation as well. Right now, federal regulations require certified EHR systems to have the capacity to collect, store, and retrieve data on sexual orientation and gender identity. So it's really important that we all start collecting this data routinely, along with other demographics that we get from patients. And also documenting pronouns and a preferred name in an EMR will make your life a lot easier as well, and show the patient that you show a lot of respect to your patients. And I think it's important that we start including sexual and gender minority patients and DEI efforts. So I think it really goes along with diversity, equity, inclusion efforts. And this is something we should be mindful of. So far in dermatology, we're not doing a great job in terms of collecting data on sexual orientation and gender. So there was one study that looked at this about 10 years apart, so 2007 through 2009, and more recently 2017 through 2019, and basically found that almost no studies were reporting information on sex or gender identity. So we can definitely do better. And we should also be mindful of for clinical trials, especially for psoriasis, collecting data and recruiting sexual and gender diverse patients and making sure that we report this in corresponding articles. To conclude, SGM individuals face numerous different health disparities and barriers to care. Our patients with psoriasis who are at SGM have unique considerations regarding comorbidities and treatment, and I think all of us can do a better job in terms of data collection and reporting. And just some resources for the FENX toolkit. And with that, I'd like to conclude.
Thank you so much. That was amazing. I know that we had asked at registration for you guys to send in a few of your questions. A lot of them were answered by this presentation. So if you have any more, please submit them through the chat and we'll get them answered at the Q&A panel at the end of the webinar. That was amazing. Thank you again for being here. I have here Mark Parikka to add the patient perspective. Mark researched and found the NPF in 2007, and he's been an active member of the Southern California chapter, attending support groups, Team NPF cycle, and every single San Diego walk. He's been very involved with the Western Advocacy Committee and attended Capitol Hill Day in 2010. Mark has attended conferences in San Francisco and DC and has been asked to speak at various NPF conferences. The work Mark has done as a volunteer is crucial to advancing our mission here at the NPF, and we're so grateful for all he does and for being here with us today to share his journey. So with that introduction, I pass the mic to you, Mark.
Hi, thanks. Well, again, they covered a lot of things. It's interesting because I just had my annual physical yesterday with my doctor, and I actually asked him about monkeypox. The list of risky things, I didn't qualify for that. So either I'm not living or I'm doing the right thing. Either way, he said I don't have to worry. And of course, he did bring up the smallpox vaccine. I guess you can get a booster, but my feeling is just like I didn't want to skip ahead with the COVID vaccine. If it's unnecessary, I won't do it. I guess the only thing I can add is, all of us, gay or straight, psoriasis affects us in terms of how we look. And in my community, it's magnified, even more so because, we're all judged by what our age is and what our body is and, blah, blah, blah. if I were single, which I'm not, I suppose it would matter more. Um, but, psoriasis for me developed, as you indicated, when I was in my early 40s, completely out of the blue, no clue whatsoever. But I was already in my relationship by, well, he would say too many years, but by a lot. And, I didn't have to go through what a lot of individuals do. A couple just joined our group last fall, and this was very early on in their relationship. So I guess I would just have to say that, well, actually, one quick story, and then I guess that's about it. We were on our 20th, and we had gone to Hawaii, and I was already dealing with an infection, and my then derm didn't warn me about going in the water, because in that warmer water, nothing dies. And I picked up an infection which only progressed and got worse. I also was on Waikiki Beach, and a lifeguard looked at me and said, "What's wrong with you? Why are you going into the water?" So I'm like, okay, well, oh, excuse me. I'm sorry about that. So I'll find another beach. Um, and, went through that. But I think a lot of us, go through things like that. Um, I'm very lucky. I am healthy. I've done a lot of things, especially in the last probably 7 years, to even make myself more so. I am on medication. I have a great derm who the foundation well knows about, and I just am mindful of my disease, and I'm not ashamed. I mean, I talk about it. I'm very open about it. It's like any autoimmune disease. I don't care what it is, whether it be this, that, or the other thing. Sure, there are situations where people may put themselves at risk, but still, it is a disease. And, I just feel it's important just to be open about it. And I guess like I said, and as a gay man or in the gay community, um, it's just something we all deal with. If it's not this, it's something else. My weight isn't right, or, I'm not 35 anymore and I don't go to the gym every day and blah, 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 blah. And I'm pretty much over that at 56. So anyway, I guess that's it. And oh, you forgot, I did go to Chicago when was Chicago? Whenever Chicago was, you had a volunteer event there. I want to say 2017, but my memory isn't what it used to
The
be. So I've been
community
to,
conference?
yeah, there was a conference. I want to say it was 17, but I can't remember now. So I've been to a bunch of them. And then I guess what was it well, 17, I think in 17, no, 18, did you have something in Orange County? Kind of like a regional thing? I don't know, whatever.
You've
I've been
been
to a
at the
bunch of stuff.
NPF longer than I have, Mark, so
Yeah, well, like I said, I've been involved since 2008. I only missed the first one, but that was because I wasn't aware of it until it was too late. And we have a great group in San Diego, but I think you all know that at the foundation. We're very, very lucky here. We've got people that are lifelong friends. We like each other.
So, Mark, just a quick question on my end. Did you have any issues like with your journey of getting diagnosed, or was it pretty smooth sailing for you?
Yeah, actually, it was the weirdest thing. It started in the winter of 2006 around the holidays when I noticed a spot on my ankle. I don't remember which one it was. And I had always, as a kid, had acne. So when things started to kind of pop up, I thought it was just that, oh, go figure, my 40s. And my GP recommended a derm, and he looked at me and he thought it could have been eczema, and then he did a biopsy, and then it was diagnosed. So it wasn't that difficult of a diagnosis because he did do a biopsy right away. He didn't do any guessing. And at that point, it was such where it was controllable with topical, but it quickly got out of hand as I moved into the summer. And at that point, I should have made a decision, but going on to a biologic is a decision, and I'm a cancer survivor too.
Mm.
And with some biologics, there's a risk. So I guess I would have to say it was a pretty quick diagnosis. My derm at that time didn't really mess around.
Well, that's great to hear. I do have some questions coming in from the chat, so I wanted to open up the Q&A channel for panel for anyone that has any questions. The first question I have, and Dr. Mash, you did kind of answer a part of it, but I just want to read it in full.
Mhm.
So it says, does being the LGBTQ plus population place an individual at greater risk for developing skin disorders? And are treatment options affordable? What patient assistance programs are offered?
So I guess the basic answer is that we don't really know because a lot of this stuff is so understudied. So really, if you're looking at population-based research, we've done a pretty horrible job at collecting what's termed SOGI data, so sexual and gender identity data. There are very few places that have been great about collecting this. They've just started to collect data on this. Fenway Health, actually, where I work, has been a big leader in collection of this data. So we actually have a very rich data set where I work, but we're kind of underpowered. This is one community health center, so we can't make blanket statements about anything. But we do know we have kind of looked at this risk of psoriasis among different sexual and gender diverse patients, and we found that prevalence is about the same as cisgender heterosexual individuals. So probably may not matter so much for psoriasis, or may not so much affect or risk for psoriasis, but I think for other skin disorders, largely unstudied.
Thank you so much. Mark, the next question is for you. It's kind of overlapping with my question, but it says, Mark, did you have any issues with treatment, and do you have any advice you would give to providers treating patients like yourself?
I think a lot of my fellow sufferers can relate to this. I went through numerous treatment options before I hit upon the right thing. So I went through a couple of biologics and blah, blah, blah. The other issue I had was back in 2017, the medication I'm on has a specific weight requirement, and I dropped a significant amount of weight over the years, and they were giving me a hassle. But my derm basically took care of it, and I haven't had a problem since then. I just think in terms of advice, you've got to do what's right for you. I know there are many people that are afraid of biologics. There are people that, want to try natural, whatever. You just have to do what's right for you. As I always joke and say, I'm going to have a quality of life, and I'm going to look good before they put me in the oven. And that's really it. I mean, I want a quality of life. Again, I'm an active person. I play tennis. I'm active. And fortunately, I have not had any symptoms of psoriatic arthritis. And arthritis is in my family. Now, I've often wondered if being on a biologic for so long can mask it, but I think the answer is no on that from what my dermatologist said. I would know if I had it. I've got other things, but I don't have that. So it's what you want your life to be, and what's right for you. That's really, and as you all always say at the foundation, quality derm, not a derm that gives you a facelift, a derm that knows psoriasis. And that's what my derm is. She does it all. And psoriasis is one of her main areas of expertise.
Yeah, I mean, that's great to hear. And also just, at the NPF, we always talk about collaborative care. So looking out for comorbidities and educating your patients. And at the NPF, we obviously think that it's really important to educate and empower the patients and give them, the education on themselves to make shared decision making between, the patient and provider. So I think that's really important. I'm glad that you had a good experience. I have a question for you, Dr. Mash. Have you personally been consulted on a monkeypox case yet and had to make a report to health departments?
So I have not, and that's mostly because the monkeypox cases have been at Fenway Health anyway, usually handled by the primary care physicians. But I know they have seen many cases and asked me specifically about scarring, which I have no great recommendations about treating aside from some Vaseline and like basic wound care. I did today actually just have a patient psoriasis patient who is now on a biologic who just received the Jynneos vaccine about 10 days ago and did great. No side effects, like feeling good. So that was encouraging to hear from him that it seems to be safe and hopefully effective. I think we are waiting to hear how effective it is for patients who are on immunosuppression. But I think only time will tell.
That's awesome. And one more question came in for you that says, can you speak a little bit about genital psoriasis in this population? Is there any advice you can give providers who may encounter patients who are more hesitant to share about genital psoriasis?
I think that you have to ask specifically about it because, obviously, I think, you need to ask permission before you look in these areas. And there has to be a lot of trust between provider and patient. But I think you really need to, as a physician, I always ask about it, especially in transgender, gender diverse patients. But I think that's the most important thing.
And another comment came in that I think could be to both of you, and it just says psoriatic prevention methods. So I know there's not really a way to prevent, but let's talk about maybe lifestyle changes. Maybe Mark, you can share some things that have helped, in your life, and Dr. Dommasch, maybe some things, lifestyle changes that you might, give advice to patients coming in that might want to take some action.
I'm sorry.
Oh, go ahead.
Me or you? Flip a coin? Age before beauty?
I guess I can start from my perspective. I mean, so there's nothing that we know of specifically that's going to prevent you from getting psoriasis, but we know that psoriasis is associated with multiple comorbidities that may increase the risk of heart attack, stroke. So keeping a healthy weight, keeping a healthy diet, exercise, there's no magic bullet. It's kind of, what doctors always tell you to do, eat right, exercise, take care of yourself, make sure you're keeping up with your, routine health appointments. Someone's keeping an eye on your weight, your glucose levels, your HbA1c, monitoring you for things like diabetes, just keeping healthy as much as possible. Mark, if you have anything to add.
Yeah, I was just gonna say the same thing. I mean, I realize, losing weight and making changes isn't easy for everyone. For me, I was shocked how quickly it came off when I decided to get my act together. But it's everything you said, and it's the level of what your disease is. I mean, there are people that, are suffering and they have psoriasis and psoriatic arthritis, so they can't do like everything I can do or somebody else. And I think you mentioned this. I mean, know your history, know your family history, have a good doctor, GP and a derm. I understand that can be an issue depending on insurance and so forth. And again, I go back to share your story, have a community. Don't be shamed because you have a disease that is a quirk in your immune system, and there is nothing anyone did. It's just the way it is. We are just different that way than anybody else. Well, more than me. I'm different in many ways. But that's important. If there's a support group or if there is a psoriasis group in your area, reach out, be involved, because there is strength in numbers. And as we all know, the numbers that are reported are low. There are way more people suffering from this disease than what is reported. That's just obvious to all of us. at least to me.
Yeah, of course. Okay, looks like one other question. I'm not sure. We sort of touched on it, but I will just ask it. For Dr. Dommasch, it says, are there psoriatic disease risk factors associated with the LGBTQ plus community that do not exist for cis heterosexual people?
I don't know if there are necessarily risk factors that don't exist for cisgender individuals, but there is probably, and I talked a little bit about this, but there's probably what we call intersectionality. So people who have a certain dermatological condition that may be of certain demographic may be at higher risk than just like doubling, than just doubling. So there's an interaction. So for instance, patients with psoriasis have a higher risk of mental health disorders across the board. So patients of all sexual and gender identification. And then we know that sexual and gender individuals, gender minority individuals also have a higher risk of mental health disorders. And when you combine those two things, you have a much higher risk among that specific population. So I think, that may very well, similar things may very well exist for things like cardiovascular disease. So there may be an additive or multiplicative effect when it comes to like cardiovascular risk factors or risk of stroke or diabetes. So I think that's kind of what we need to study more and pay attention to.
Okay, wonderful. Dr. Dommasch, can I ask you to go to the next slide for me, please?
Sure.
And while you do that, I just want to say that there's been so many comments flooding that, aren't questions, but are just expressing appreciation for the presentation today. So thank you guys both for being here. Thank you to all the attendees. We are recording this and we'll have it available. So if there's anyone that you feel this would be relevant to and you want to share it, we'll have it available. We'll send an email out. And don't forget to just answer the post-test questions when it comes to your email so you can get CME credit for it. I just want to turn your attention really quickly to our grand rounds. We have some NPF-hosted grand rounds coming. They're all virtual, and they're starting at Psoriasis Action Month in August and leading up to World Psoriasis Day in October. They'll be every other Thursday at 8 p.m. Eastern. And we have some amazing people presenting, Dr. Lebwall, Dr. Evans, Dr. Song, so many incredible people, and we'll be talking about all different topics. I know today we talked about lifestyle. We have a module on diet and lifestyle and a bunch of other topics, pediatrics, family planning. So here's a QR code if you guys want to register. There's also the link below. And if you register and you attend, you get a free coffee certificate. So join us for grand rounds over a cup of coffee. And if you have any questions, I'm posting my email in the chat, so please reach out to me if there are any questions or if you have any other things that we didn't get to answer in the Q&A panel. But I just wanted to thank you all for being here, and this was amazing. Thank you, guys. Any additional comments to end the webinar?
Thank you so much for having me. It was
great. Thank you for being here.
Thanks.
Mark, always a pleasure. Thank you, everyone.
Thanks.
Have a great night.
Good night.